We analyzed over 77,000 real Step 1 questions. CNS infections is one of the most missed, at about 54%, usually on how the stem is worded. What it is, the core facts, how it works, then real questions ending with the most missed pattern. Let's go. Part 1. What CNS infections is. CNS infections happen when bacteria, viruses, fungi, or parasites invade the brain or its coverings, causing inflammation that can damage the nervous system. Doctors recognize them by fever, headache, and neurologic problems, then use spinal fluid tests and brain imaging to find the exact cause. Part 2. The 5 facts for CNS infections. Bacterial meningitis CSF shows low glucose, high protein, and neutrophils. HSV encephalitis classically causes hemorrhagic necrosis of the temporal lobes. Brain abscess appears as a ring-enhancing lesion on contrast imaging. Neurocysticercosis from Taenia causes cystic brain lesions with calcifications. Cryptococcus neoformans meningitis is diagnosed by India ink stain showing capsule. Part 3. How it works. When bacteria infect the meninges, the spinal fluid turns cloudy because it's packed with neutrophils, low glucose, and high protein. This turbid appearance is a classic bedside clue to bacterial meningitis. Next, HSV-1 encephalitis has a striking preference for the temporal lobes, causing hemorrhagic necrosis there. On imaging, this shows up as edema and hemorrhage localized to that region, a key diagnostic clue. Next, a brain abscess shows up as a ring-enhancing lesion on contrast CT or MRI, with a bright rim of enhancing capsule around a necrotic, non-enhancing center. Fever and focal deficits point toward abscess over other causes. Next, Taenia solium larvae lodge in the brain and form cysts, which calcify over time. CT scans typically show multiple small cystic or calcified lesions scattered throughout the brain parenchyma, a hallmark of neurocysticercosis. Next, Cryptococcus neoformans has a thick polysaccharide capsule that shows up as a clear halo around the yeast when stained with India ink. This organism causes meningitis, especially in immunocompromised patients. And finally, both brain abscess and toxoplasmosis can look like ring-enhancing lesions on imaging, but abscess presents with fever and focal deficits in normal hosts, while toxoplasmosis is classically seen in immunocompromised patients. Part 4. The questions. Question 1 of 3. A real NBME-style stem from our data. A 25-year-old man presents with 2 days of fever, headache, and photophobia, but no altered mental status. Lumbar puncture shows a CSF WBC count of 180 per microliter, with 85% lymphocytes. Glucose 58 mg per deciliter, serum glucose 92 mg per deciliter, and protein 55 mg per deciliter. Which of the following mechanisms best explains this patient's CSF glucose level? Lock in your answer. Watch what each phrase is doing. No altered mental status. Read this as a milder clinical course typical of viral meningitis, because viral meningitis generally causes less severe inflammation and toxicity than bacterial meningitis. 85% lymphocytes. This signals lymphocyte-predominant pleocytosis, characteristic of viral meningitis, because viral meningitis provokes a lymphocytic immune response rather than the neutrophilic response seen with bacterial infection. Glucose 58 mg per deciliter. This means normal CSF glucose, arguing against bacterial or fungal meningitis, because viral organisms do not consume glucose within the CSF, the way bacteria and fungi do. It's D. Viruses don't metabolize glucose the way bacteria or fungi do, so CSF glucose stays near normal, even though lymphocytes are elevated. That combination, lymphocytic pleocytosis with normal glucose, is the signature of viral meningitis. Now the others. A. This explains mild protein elevation seen in viral meningitis but doesn't account for the glucose finding being asked about. B. This applies to fungal meningitis, which also lowers glucose through direct consumption. Not relevant here since glucose is normal. C. This describes bacterial meningitis, which produces low glucose and neutrophilic pleocytosis, not this patient's picture. E. Neutrophils aren't the driver of glucose consumption, and this patient has a lymphocyte-predominant, not neutrophilic pleocytosis. Question 2 of 3. A 58-year-old woman is brought to the emergency department by her husband because of 3 days of fever, worsening confusion, and difficulty speaking. She has had 2 brief episodes of lip smacking and unresponsiveness at home. On exam, she is febrile, disoriented, and has trouble naming objects. MRI of the brain shows asymmetric hyperintensity with areas of hemorrhage in the medial temporal lobes bilaterally. Which of the following is the most likely diagnosis? Commit to an answer before the break. Down. Let's decode the wording. Difficulty speaking. This signals aphasia, suggesting dominant temporal lobe involvement, because the language centers overlap with the temporal lobe regions destroyed by HSV necrosis. Lip smacking and unresponsiveness. This means complex partial focal seizures arising from temporal lobe irritation, because necrotic, inflamed temporal lobe tissue becomes an epileptogenic focus. Hemorrhage in the medial temporal lobes. Here, this is the classic imaging finding of HSV encephalitis, because HSV-1 causes necrotizing inflammation that preferentially damages the medial temporal and orbitofrontal cortex after traveling along olfactory or trigeminal nerve pathways. The answer here is E. HSV-1 travels along the olfactory or trigeminal pathways and preferentially destroys the medial temporal and inferior frontal lobes, producing that classic hemorrhagic necrosis with edema on MRI. The seizures, aphasia, and behavioral change, plus RBCs and lymphocytic pleocytosis on CSF, fit this localization pattern far better than the other pathogens listed. Now the others. A. Produces ring-enhancing lesions at gray-white junction or basal ganglia in immunocompromised hosts, not hemorrhagic temporal necrosis. B. Classically involves the basal ganglia, thalami, and brainstem, presenting with flaccid paralysis, not the temporal lobe hemorrhagic pattern. C. Typically causes a diffuse ventriculoencephalitis in immunocompromised patients, not localized temporal hemorrhage. D. Shows a ring-enhancing mass with central necrosis and surrounding edema, usually from contiguous spread or hematogenous seeding, without the temporal predilection or RBC-rich CSF seen here. Question 3 of 3. The last one before the challenge. A 34-year-old man with poorly controlled HIV infection, CD4 positive count 80 cells per microliter, presents with a 2-week history of worsening headache, low-grade fever, and mild confusion. He has no nuchal rigidity or photophobia. Brain MRI shows scattered gelatinous cystic soap bubble lesions in the basal ganglia, and lumbar puncture reveals an opening pressure of 32 centimeters H2O. Which of the following CSF profiles is most likely in this patient? Pick your answer. Let's walk the stem. CD4 positive plus count 80 cells per microliter. This means severe HIV-related immunosuppression that predisposes to cryptococcal meningitis, because the capsule of Cryptococcus neoformans resists phagocytosis and the organism disseminates unchecked once cell-mediated immunity falls below a critical threshold. Soap bubble lesions. Here, this is cryptococcomas, gelatinous pseudocysts formed by accumulated capsular polysaccharide in brain tissue, because the polysaccharide capsule accumulates in perivascular spaces, creating cystic, mucoid-appearing collections on imaging. Opening pressure of 32 centimeters H2O. This tells you markedly elevated intracranial pressure, typical of cryptococcal meningitis, because the capsular polysaccharide clogs arachnoid villi and impairs CSF drainage, raising intracranial pressure. The answer is A. Cryptococcal meningitis produces a mononuclear, lymphocyte-predominant pleocytosis with elevated protein, but the capsular polysaccharide does not consume glucose the way bacteria do, so glucose stays normal. This pattern is what separates it from bacterial meningitis, which drives glucose down through bacterial metabolism. Now the others. B is classic for tuberculous meningitis, which does deplete CSF glucose unlike cryptococcal disease. Fits viral aseptic meningitis, which typically spares protein and glucose levels. D would suggest a very early or partially treated bacterial infection, not the chronic cryptococcal picture described here. E describes acute bacterial meningitis, where bacteria consume glucose and neutrophils dominate the response. Last question. In our data, this is the most missed pattern for CNS infections. A 29-year-old woman who immigrated from rural Guatemala 3 years ago works as a live-in nanny for a family in the United States. She presents with a first-time generalized tonic-clonic seizure and a 2-month history of intermittent headache. She reports that she and the household always eat well-cooked pork. but mentions that the employer's teenage son has passed visible proglotid segments in his stool several times over the past year. Vital signs are normal, and she is afebrile. MRI of the brain shows multiple small ring-enhancing lesions with scattered calcified foci throughout the cortex and basal ganglia, giving a Swiss cheese appearance. Serum antibody testing for cysticercal antigen is negative, and a stool, ova, and parasite exam performed on the patient herself is also negative. Which of the following best explains the mechanism by which she most likely acquired this infection? Pick your answer. Read between the lines here. Well-cooked pork. Read this as this rules out her acquiring larval cysts directly from meat, because eating larvae in undercooked pork produces intestinal taniasis in the eater, not neurocysticercosis, since cysticercosis requires ingestion of eggs rather than larvae. Past visible proglotid segments in his stool. This signals the household member is the definitive host, harboring the adult tapeworm, because an adult Taeniasolium in the intestine sheds egg-containing proglottids in feces, which can contaminate food or hands and be ingested by others. Multiple small ring-enhancing lesions with scattered calcified foci. This means this is the classic radiographic pattern of neurocysticercosis, because larvae encyst in brain parenchyma and eventually calcify as they die, producing the mixed cystic and calcified Swiss cheese appearance on imaging. Serum antibody testing for cysticercal antigen is negative. Here, this is a negative serology does not exclude neurocysticercosis, because serologic tests for antiparasitic antibodies in cysticercosis are known to be unreliable and can be falsely negative despite active infection. It's E. The employer's son is passing proglottids, meaning he is the definitive host carrying the adult tapeworm and shedding eggs in his stool. She almost certainly ingested those eggs through contaminated food or hands, and the eggs hatched and disseminated hematogenously to her brain to form the calcified cystic lesions seen here. Now the others. A. Fits the classic mimic of ring-enhancing brain lesions in immunocompromised patients, but there is no cat exposure or immunosuppression here, and the calcified Swiss cheese pattern favors cysticercosis. B. Describes how a person develops intestinal taniasis by eating cysticercae in meat, but she eats only well-cooked pork. And eating larvae in meat gives you the adult worm, not neurocysticercosis. C would explain a solitary casating tuberculoma from a pulmonary source, but there is no pulmonary or systemic infection described, and the multiple calcified cystic lesions fit neurocysticercosis better. D is the mechanism behind amoebic liver and brain abscess, which typically produces a single large necrotic lesion rather than multiple small calcified cystic lesions. That's CNS infections. Concepts, 3 questions, and the most missed pattern, done. If you want the full system, our Step 1 Pass program is linked in the description. Here's a look at what's inside. If this helped, like, subscribe, and share it with a friend studying for Step 1. A new most missed topic drops every day.